Welcome to the Deep Dive. We're here to cut through the noise and get to the heart of things. And today, we're looking at something really quite surprising in equine health.
Yeah, it turns out the most common heart defect horses are born with is, well, literally a hole in their heart.
A hole in the heart. That condition is called a ventricular septal defect, or VSD.
Exactly.
And that's our mission for this deep dive.
Yeah.
Really unpack what VSDs are, how they affect horses specifically, how vets figure them out, what the outlook is.
And crucially, what can actually be done, and maybe more importantly, what often can't be done, especially in horses.
Right. We've gone through a lot of veterinary reviews, research papers on VSDs to kind of give you the fast track to understanding this.
Okay, so let's start with the basics. What is a VSD? Well, it's a congenital defect.
Mean they're born with it.
Correct. Present right from birth. It's essentially a hole, an opening in the wall between the heart's two main pumping chambers.
The ventricles.
The ventricles, yeah. That dividing wall is called the interventricular septum.
And does it matter where exactly that hole is located?
Absolutely. Location is key. VSDs can technically occur anywhere along that septum.
But is there a common spot?
There is. Most often we see them in what's called the membranous portion. That's sort of the thinner upper part of the septum.
Okay.
But you can also find them near where the blood flows out, near the valves between the upper and lower chambers, or even within the thicker muscular part.
So you said this is the most common congenital heart defect in horses. How common are we talking?
It's surprisingly prevalent. Estimates range from about 0.1% to maybe 0.5% of all horses.
Wow.
Which might not sound huge, but it's reported to be up to 6 times more frequent than any other congenital heart issue in horses.
That really makes you wonder why. Why this specific defect?
That's the million-dollar question, isn't it? And it leads right into genetics. There's a very strong suspicion, it's widely believed, that VSDs are likely heritable in horses.
Heritable.
Yeah. The exact genes aren't pinned down yet, but we definitely see it more often in certain breeds.
Like which ones?
Welsh Mountain Ponies, Arabians, standard breds are often mentioned. Arabians in particular seem to be overrepresented in the cases we see.
Really?
Mm-hmm. Which is why places like UC Davis are actively researching the genetic links in Arabians.
So if it's likely inherited, what's the advice for breeders?
Well, the strong recommendation generally is that horses diagnosed with a VSD should not be used for breeding.
Right. To try and reduce how often it occurs.
Exactly. It's about managing the prevalence in the population.
Okay, so we know it's this hole, it's common, likely genetic. Let's get into the mechanics. How does this hole actually mess with the way the horse's heart works?
Right, this is where the physiology gets interesting. So normally you have the left ventricle pumping oxygenated blood out to the body, that's the high pressure side.
Okay.
And the right ventricle pumps deoxygenated blood just to the lungs' lower pressure.
Makes sense.
With a VSD, that hole connects these two sides. And because the left side has much higher pressure...
Blood flows from left to right through the hole.
Precisely. You get what's called a left to right shunt. Blood that should be going out to the body takes a shortcut into the right ventricle.
And where does that extra blood go then?
It gets pumped back to the lungs, along with the normal amount of blood from the right side. Then it comes back to the left side of the heart, the left atrium and left ventricle.
Ah, so the left side gets overloaded.
Exactly. It's called volume overload. The left heart chambers have to handle more blood than they should, cycle after cycle.
And that causes changes.
Over time, yes. The left atrium and ventricle tend to enlarge or dilate to cope with the extra volume. The blood vessels in the lungs can also be affected. And the right ventricle might enlarge too, dealing with that extra flow coming through the hole.
So it puts a strain on multiple parts of the heart. I'm guessing the size of the hole makes a big difference here.
Huge difference. Size and location are really the key determinants of severity.
Okay.
Small VSDs, we often call them restrictive. The hole is small enough that it restricts or limits how much blood can actually shunt across.
And what does that mean for the horse?
Often, surprisingly little. If it's small and restrictive, it might cause minimal or even no real functional problems. These horses can often live normal lives, show no signs.
Maybe even perform athletically.
Sometimes, yes. Maybe not elite level competition, but certainly moderate activity is often possible.
That's somewhat reassuring. But what about the bigger ones? The non-restrictive VSDs.
Yeah, that's a different picture. Large, non-restrictive VSDs allow a significant amount of blood to shunt across. These lead to much more substantial cardiac insufficiency.
And more obvious problems for the horse.
Definitely. More overt clinical signs, and they're the ones that are much more likely to lead to serious complications down the road.
What sort of complications are we talking about?
Well, that chronic volume overload on the left side can eventually stretch the ring around the mitral valve, the valve between the left atrium and ventricle.
Causing it to leak.
Exactly. That's secondary mitral regurgitation. Also, the increased blood flow through the lungs over a long time can damage the pulmonary arteries. They can narrow.
Leading to high blood pressure in the lungs.
Right. Pulmonary hypertension, that's a serious development.
And is that related to this Eisenmenger syndrome you mentioned?
It is. Eisenmenger's is sort of the end stage, the most critical point. If pulmonary hypertension gets severe enough, the pressure in the right ventricle can eventually become higher than the left.
So the pressure gradient flips?
It flips. And when that happens, the shunt reverses.
Hmm.
Now you have deoxygenated blood flowing from the right ventricle through the VSD into the left ventricle and out to the body.
Bypassing the lungs entirely.
Bypassing the lungs,
Right.
which means the horse isn't getting enough oxygen.
What does that look like?
You see signs like cyanosis, the gums and membranes turn bluish, extreme fatigue, severe intolerance to any exercise. Well, the prognosis is grave once that happens.
That sounds incredibly serious. Are there other potential issues too?
Yeah, depending on the location, like if the VSD is right under the aortic valve, it can sometimes lead to problems with that valve leaking too, aortic incompetence.
Okay, so a lot can go wrong, especially with larger defects. How do vets actually figure out if a horse has a VSD, especially if the signs can vary so much?
Well, the classic sign everyone listens for is a heart murmur.
Right.
Usually a loud, kind of coarse sound heard throughout the heartbeat, pansystolic, and often loudest on the right side of the chest.
But you said earlier it's not always that simple.
Exactly. And this is crucial. With very large VSDs, or if the shunt has reversed into that Eisenmenger situation.
The murmur can be quiet or gone?
Paradoxically, yes. The pressure difference might be minimal or the flow pattern changes, so the murmur can become very faint or even disappear entirely.
So just listening isn't enough. You can't rely on hearing a loud murmur or the lack of one.
You really can't. It's a vital clue, but not the whole story.
What other signs might owners notice then, besides performance issues or maybe lethargy?
You might see difficulty breathing, maybe a cough, especially in foals, sometimes poor growth. Some horses develop visibly pulsating jugular veins in their neck. And then the more severe signs we mention, like cyanosis, or in really bad cases, even collapsing or fainting spells.
So given all that variability, what's the definitive diagnostic tool? How do vets get the real picture?
The absolute gold standard, the best non-invasive way to diagnose and really understand a VSD is echocardiography.
An ultrasound of the heart.
Exactly. Cardiac ultrasound.
What can you see with that?
The basic 2D imaging lets us directly see the hole. We can measure its size precisely, see exactly where it is. We also measure the size of the heart chambers to see if they're enlarged from that volume overload.
Are there specific measurements that correlate with severity?
Yes. For instance, a VSD diameter under about 2.5 centimeters, or if the ratio of the VSD size to the size of the aorta root is less than about 1:3, that generally points towards a more restrictive, less impactful defect.
And what about Doppler? I know that's used with ultrasound.
Doppler echocardiography is indispensable. It uses sound waves to look at blood flow.
So you can see the shunt.
You can confirm the shunt is there, yes. But critically, you can see the direction of the flow. Is it left to right, or has it reversed? And you can measure the speed of the blood flow through the defect.
Why is the speed important?
It tells us about the pressure difference. A very high velocity, say over 4 or 4.5 meters per second, means there's a big pressure difference between the ventricles.
Which means the hole is small, restrictive.
Usually, yes. It indicates a restrictive VSD, limiting the flow. Conversely, a low velocity, maybe 3 meters per second or less, suggests the pressures are starting to equalize.
Meaning a large, non-restrictive hole.
Exactly, a very hemodynamically significant shunt. That velocity measurement is a cornerstone for prognosis.
Makes sense. Is 3D echo used much in horses?
It's available, offers more detail, but it's less commonly used than standard 2D and Doppler for VSDs currently.
Okay, so echocardiogram is key. What about ECGs, electrocardiograms?
Also very important, primarily for detecting arrhythmias, abnormal heart rhythms.
Right, which you mentioned can be a complication.
Yes, and for horses, especially athletes, we often need more than just a resting ECG strip.
Like Holter monitoring.
Exactly. A Holter monitor records the ECG continuously for 24 hours while the horse is doing its normal thing in the stall out in the paddock.
Why is that better?
It gives us a much clearer picture of the resting heart rate, and crucially, it catches arrhythmias that might only happen occasionally, or maybe only at night, or during low-level activity.
And what about during real exercise?
That's where exercise ECG comes in. We monitor the heart rhythm while the horse is actually working, usually on a treadmill or sometimes under saddle.
Why is that so critical? You mentioned exercise-induced arrhythmia as being a bad sign.
It's vital because some dangerous arrhythmias only show up or get significantly worse under the stress of exertion.
And that relates to the risk of
Sudden cardiac death. Even if a horse seems fine resting, exercise can reveal underlying electrical instability in the heart muscle caused or worsened by the VSD hemodynamics. Finding significant arrhythmias during exercise is a major red flag for safety.
understood. Are there any other tests commonly used? X-rays, blood work.
Chest x-rays, or radiographs, can be helpful to look for signs of fluid buildup in the lungs if we suspect congestive heart failure. Blood tests are mostly used to check for other underlying issues, like electrolyte imbalances that could make arrhythmias worse.
And things like cardiac MRI.
MRI gives amazing detail in people, but it's not really routine for horses yet for diagnosing VSD's practical challenges, cost, but maybe in the future.
Okay, so you've done the exam, the echo, maybe an ECG, you have the diagnosis. What's the actual outlook for the horse? How variable is the prognosis?
It's extremely variable. It really depends on those factors we measured: the size, the location, the shunt velocity and direction, and also the age the horse started showing signs.
So what scenario gives the best prognosis?
Generally, a horse with a small VSD, say under that 2.5 centimeter mark that's restrictive, meaning high shunt velocity, usually over 4.5 meters, and located in the membranous part. Those horses often do very well.
Normal life expectancy, performance.
Often, yes. Normal lifespan, and many can perform athletically, perhaps just not at the absolute peak level. Some racehorses with small VSDs have competed successfully.
Okay, and the other end of the spectrum.
For horses with large defects, maybe over 4 centimeters that are clearly non-restrictive, low shunt velocity, the prognosis is much more guarded. Shortened athletic career, reduced life expectancy, and as we said, if they develop pulmonary hypertension and that right-to-left shunt Eisenmenger's, the prognosis is grave.
Does the age when they first show signs matter?
It seems to. Horses that develop clinical signs like poor growth or exercise intolerance when they're very young often have a worse outlook. It suggests a more severe defect causing problems early on.
Which points towards those major complications you described earlier.
Exactly, like congestive heart failure. If a horse with a large VSD develops signs of left-sided heart failure, that difficulty breathing, coughing, fluid buildup.
What's the prognosis then?
Once CHF develops, it's usually guarded to grave for long-term survival. Managing the symptoms becomes the focus, and often, unfortunately, euthanasia has to be considered.
And the arrhythmias, leading to that risk of sudden death.
Yes. The altered blood flow and chamber enlargement can definitely trigger arrhythmias, sometimes dangerous ventricular ones. And that risk of sudden cardiac death, especially during exercise, is a major concern for any horse with a significant VSD.
It really highlights why that exercise testing is so important for safety.
Absolutely. You need to know if exertion triggers instability.
So let's talk management. What can actually be done for a horse with a VSD? You've mentioned it's complex.
It is, and it has to be tailored to the individual horse. For those small asymptomatic VSDs we talked about.
The ones found, incidentally.
Right. They might not need any active treatment at all. Just regular checkups, maybe an annual echocardiogram to make sure nothing's changing.
But for the ones with bigger defects or showing signs,
Then medical management becomes the mainstay.
what kinds of medications?
If there's heart failure, we use diuretics like furosemide to manage the fluid. ACE inhibitors, drugs like enalapril or benacepril, might be used to try and slow down the heart's remodeling and disease progression. And then there are various antiarrhythmic drugs if rhythm disturbances are a problem.
But you mentioned challenges with those drugs in horses.
Big challenges. Quinidine, for example, a traditional antiarrhythmic, can have really severe side effects in horses. Call it collapse. Even death are reported quite frequently, maybe up to 75% incidence of some side effect. It's tricky to use.
Wow, that's high.
Yeah. And another one, amiodarone, is difficult because horses just don't absorb it well or consistently when given orally. So getting the right dose into their system is tough.
Why are these drugs so much harder to use in horses compared to, say, people or dogs?
It boils down to what some call a therapeutic gap. We just don't have the same depth of knowledge about basic equine heart function, the electrophysiology, or how horses metabolize and handle drugs, the pharmacokinetics compared to other species.
You can't just extrapolate from human medicine.
Not at all. Horses are unique. Their size, their digestive system, their metabolism. It all affects how drugs work, and sometimes we lack the basic data to predict that reliably.
Are there non-drug approaches too, like diet?
Yes, for horses in heart failure, reducing salt intake is often recommended, and managing electrolytes carefully is important, especially if they're on diuretics or have arrhythmias.
Okay, now for the big question, and maybe the biggest difference. What about surgery? Can you just close the hole like they often do in human babies or puppies?
This is where equine medicine really diverges. The short answer is generally no. Direct surgical repair of VSDs in horses is not common practice. It's not an established routine procedure.
Why not?
Think about the scale. It would require major open chest surgery, likely needing to remove ribs, and putting the horse on cardiopulmonary bypass, a heart-lung machine.
Which sounds incredibly complex and risky for a horse.
Extremely. And frankly, it's usually not considered financially feasible or practical, especially if the goal is to return the horse to athletic function. The recovery, the risks, the cost, it's just not a standard option.
So when you hear about catheter procedures in horses, that's not for closing VSDs.
Typically, no. Catheter-based interventions in equine cardiology are mostly used for treating certain types of arrhythmias, like ablating abnormal electrical pathways. They aren't routinely used to place devices to close VSDs like they might in smaller animals or humans.
That's a fundamental limitation then. No surgical fix readily available.
It is, and it really shapes everything. The prognosis, the management goals, we're managing the consequences, not usually fixing the underlying hole.
Which brings us back to exercise. How do you advise owners?
It has to be carefully individualized based on the echo findings and any ECG results. Small, stable VSD. Maybe okay for continued work with monitoring.
But moderate to severe.
If the VSD is significant, especially if there are arrhythmias, particularly during exercise, or signs of heart strain like a very high heart rate, then exercise needs to be severely restricted or stopped altogether. Retirement from athletic work is often necessary for safety.
Because of that sudden death risk.
But because of that risk, it's just not worth it.
And just to circle back one more time, the breeding advice remains firm.
Absolutely. Given the strong suspicion of heritability, the recommendation is consistently against breeding horses diagnosed with VSDs.
Okay, so looking ahead with these management challenges, especially the lack of a surgical fix, where does hope lie? What's the future direction?
A lot of hope rests on genetics. The ongoing research, particularly trying to identify the specific genes responsible for VSD predisposition, especially in breeds like Arabians.
If they found those genetic markers, what would that allow?
That would be a game changer. It could lead to reliable genetic tests.
So breeders could screen their horses before breeding.
Exactly. You could identify carriers or horses at higher risk. It would allow for much more informed breeding decisions aimed at reducing the frequency of VSDs in the horse population over time.
That can make a huge difference for breed health long term.
Potentially, yes. A significant contribution to genetic health and welfare.
All right, so let's try and pull this all together. We've learned VSDs, these holes in the heart wall, are surprisingly the most common birth defect of the heart in horses.
Right. And their impact varies hugely from almost nothing with small restrictive ones to severe heart failure and even sudden death with large ones.
Echocardiography, the heart ultrasound, is absolutely key. It's the gold standard for diagnosis, for measuring the defect, assessing blood flow, and figuring out the prognosis.
Indispensable. It gives us the blueprint for management.
And that management involves medication for symptoms, careful exercise planning, but uniquely in horses, not typically surgical repair of the hole itself.
That's the crucial distinction. Medical management and risk assessment are the core strategies.
So early and accurate diagnosis using echo is really paramount.
It lays the foundation for everything that follows: prognosis, management plan, safety recommendations.
It may be a final thought for our listeners to ponder. Given this strong genetic link and the fact that surgery isn't really an option for horses right now, how might breakthroughs in genetic screening or perhaps future non-invasive therapies that we haven't even touched on completely change the outlook for horses born with VSDs? What could that mean for equine vets and horse owners down the line?
It's definitely something to think about, the potential to shift from managing consequences to preventing the problem in the first place.